Here we'll walk through management of hypokalemia. Hypokalemia is a serum potassium of less than 3.5 milliequivalents per liter. We can divide hypokalemia into severe at levels below 3, in which we use IV replacement, and mild to moderate at ranges of 3.0 to 3.4, in which we use oral replacement. In severe hypokalemia, we first start with an infusion of potassium chloride at 20 to 60 milliequivalents, diluted in saline at a rate of 10 to 20 milliequivalents per hour. We go slowly to avoid peripheral vein irritation and sudden shifts in potassium. Indicate that we reassess potassium levels every 2 to 4 hours to determine about further treatment. We should have the patient on telemetry to monitor for life-threatening cardiac arrhythmias. Remember that insulin is a treatment in hyperkalemia, so we should avoid co-administration with insulin early on, as insulin will drive potassium into the cells. Similarly, we should use saline instead of dextrose to mix the potassium in, because dextrose can stimulate insulin release, which again would drive potassium into the cells. Once potassium levels rise above 3.0, we transition to oral replacement. Again, we use potassium chloride now in dosages of 10 to 20 milliequivalents 2 to 4 times a day, which comes out to anywhere from 20 to 80 milliequivalents per day. Note that other formulations such as potassium citrate and potassium phosphate exist but are less potent. It's also a helpful tip to know that bananas have about 10 to 15 milliequivalents of potassium. Indicate that the goal is a potassium of 3.5 to 5. Pay attention for rebound hyperkalemia and cardiac arrhythmia. Some additional considerations include checking for concomitant hypomagnesemia, which often accompanies hypokalemia and can directly hinder potassium correction. When there's continuous potassium wasting in the urine, potassium-sparing diuretics such as amiloride can be added. We should also look for underlying causes of hypokalemia, which primarily occurs from decreased dietary intake, increased cellular uptake, and increased renal and GI losses. Hypokalemia can present with muscle cramps and weakness to the point of rhabdomyolysis, as well as numerous cardiac arrhythmias. Notable EKG changes are U waves and flattened T waves. As a final note, for redistributive hypokalemia found in hypokalemic thyrotoxic periodic paralysis, we administer IV propranolol to decrease sympathetic tone. The increase in potassium will dramatically improve the muscle weakness. This concludes our management algorithm.